Hello, everyone, and thank you to the organizers of the 5th Pediatric Autoimmune Liver Disease Symposium and the Family Day for the opportunity to share some of the exciting things that are happening within the Improved Care Now network and the Autoimmune Liver Disease Network for Children. I'm excited to share some of those opportunities in this talk. I have no disclosures relevant to this topic. As we both sort of talk about Improved Care Now and the A-Link network within Improved Care Now, I thought it would be good to sort of share what is a learning health network and how embedding another improvement network within existing learning health network can augment and improve learning and improvement opportunities. Learning health networks are becoming more relevant as they have shown to be saving thousands of lives, helping hundreds and thousands of patients and families in improved outcomes, as well as cutting hundreds of millions of dollars in costs of care and at the same time accelerating research by more than a decade. Learning health networks bring together large engaged communities of relevant stakeholders like patients, clinicians, and researchers who are then combining their insights and expertise with the best science, tools, and technology. We've all witnessed the power of this kind of radical collaboration when we came together to develop a COVID-19 vaccine, which was 95% efficacious, while exceeding the typical vaccine development timeline by more than 1,000%. Learning health networks rise to the challenge of hundreds of diseases like we rose to the challenge of the global pandemic. But before we can sort of talk about the A-Link network within Improved Care Now network, let's talk a little bit about what is a learning health network or a system. It's a community of patients, families, clinicians, and researchers working together and using data to improve health outcomes. The Institute of Medicine defined a learning health system or a network as a system which is designed to generate and apply the best evidence for the collaborative healthcare choices of each patient and provider, at the same time driving the process of discovery as a natural outcome or outgrowth of patient care, while ensuring innovation, quality, safety, and value in health. In other words, it's a shared purpose which then drives better population health. Our learning health network comprises of these 4 elements or buckets that are noted here on this slide. The first bucket or element comprises of engaging clinicians, patients, researchers as a working community to take and assume responsibility and accountability for the patient's outcomes. In this community, everyone can make a difference and contribute to improved outcomes. The second element is a shared, transparent performance and outcomes data process where the stakeholders can learn and improve health together. The third element or bucket of this learning health network is a collaborative space where improvements can be scaled up. And the last element is a robust, reliable methodology to inform and drive outcomes, care, and research output. In Improved Care Now, we help patients, families, clinicians, and researchers work together to speed innovation and scale up lessons learned. Collaboration in Improved Care Now is characterized by the spirit of all teach, all learn. We collaborate to freely share information, experience, tools, and results related to the treatment of these diseases. We use the network's quality improvement technology to identify care gaps and then use the same methodology to actually bridge those gaps and improve the care received by the patients. We use the same quality improvement mindset to understand these gaps as it relates to health disparities and inequities. We share, aggregate network level data as well as center level data to drive improvements via repeated plan, do, study, act cycles and small tests of change. We share these improvements at our twice a year community conferences to scale up learnings and improvements all across the network. The framework of Improved Care Now and how it achieves these parameters is the framework that we call as Pathway to Mastery framework. It delivers or is comprised of three main buckets. We call these buckets as foundations bucket, an outcomes-based bucket, which is comprised of two sub-elements of achieving remission and achieving sustained remission. And the third bucket is that of Trailblazer or an innovation community. The foundations element or bucket focuses on foundational work on pre-quality improvement work, data gathering, and our international partners. The outcomes-based bucket, as I previously shared, consists of the two sub-buckets of achieving remission, which is focusing on multidisciplinary pre-visit planning and population management. And the second sub-bucket of achieving sustained remission, focusing on adherence and clinical standardization and personalized care. Our innovative community, also known as the Trailblazers, is focused on engagement research, a time-limited COVID response lab, and the autoimmune liver network for children, as we'll be sharing in the next few slides. This A-Link network was launched in the summer of 2022. It's the summer of 2020, after the last Center for Autoimmune Liver Disease Symposium. It's an autoimmune liver node within an existing learning health network known as Improved Care Now. It affords us a unique opportunity to stand up a learning health network within an existing learning health network. It can augment existing knowledge of improvement and collaborations through team building and by providing on-site contact experts with their Improved Care Now collaborators. It also leverages the knowledge and existing infrastructure, and also at the same time minimizes the cost and lift for centers and divisions so that they can actually benefit globally with the existing expertise and staff. These opportunities for different stakeholders are noted here on this slide. For the parents and families and patients, this opportunity augments improved outcomes, also leverages improved development and sharing of knowledge, and leads to peer support and networking opportunities. For the clinicians and researchers, these are the same bullet points for improving outcomes, development and sharing of knowledge, peer support and networking, but it also allows them to leverage leadership opportunities and develop unique hypothesis-driven research and discovery ideas. For the health systems, it allows them to leverage existing expertise and cost, as I previously shared, but also allows them to share resources and an intangible benefit of development of leaders, both from clinicians and researchers, but also from patients and families' perspective. With these opportunities come with some challenges. These challenges include, how do we structure the financial arrangements? What are the protocol refinements that we need to do to embed an existing protocol with a newly launched disease-focused protocol? It also affords some unique challenges and opportunities regarding legal and regulatory navigation. And also, of course, how to onboard new team members onto improvement, knowledge and methodologies and education. I also submit that while these may seem like challenges, but these are also unique opportunities like the opportunities in the previous slide. If we know how to do this and we learn how to do this, we can really scale this up all across different healthcare systems and divisions and achieve a global benefit for conditions other than the usual ones that we talk and hear about. As you will see, while it may seem that progress has been slow, we have achieved some major milestones, including completion and sign off of a memorandum of understanding between the two networks, a charter determining the functioning and scope of work of the new network, participation selection, development of framework of improvement with a key driver diagram, measures and metrics selection, development and submission of an IRB application, development of QI coaching opportunities, and defining an initiated ideal autoimmune hepatitis and primary sclerosing cholangitis disease diagnosis and classification process. Our participation sites are these sites all across the United States, both from the Northwest, California, Midwest, Southeast, and the Mid-Atlantic region. And the next slide showcases their collaborating Improve Care Now team members. Again, these are embedded, readily available resources for the A-Link team members to learn from and reach out to. Started a year ago with the Summer Center for Autoimmune Liver Disease Symposium, we have undertaken consistent and concrete measures as noted in this and next slide and discussed previously. We started off with chartering and development of the MOU right after the called symposium in August last year, followed by development of IRB protocol, data and database discussions, development of case report forms and REDCap database, creating a link page on our collaborative platform known as Hub. We also had a networking meeting in November of last year, and then we finalized the MOU measures table welcome package in December of last year. Also started work on developing a parent working group for the A-Link team in December as well. The new year got started off with our AP call kickoff, and we have continued to reach major milestones with ongoing monthly AP calls, leadership calls. The AP calls are focused on some foundational QI work, whereas leadership calls are focused on high-level discussions regarding the next steps and direction of the A-Link node within Improve Care Now. We did submit the IRB application in July, and I'm happy to report that this was finalized and accepted last month. So we are off to the races starting this month. So in summary, I submit to you that this is a great and unique opportunity to leverage Improve Care Now Network's infrastructure and efficiencies for the benefit of another disease condition of a rare disease like autoimmune hepatitis and PSC. It's also an opportunity to collaborate and scale up cross-team interaction and learnings and education. It's a unique opportunity to share QI methodology across traditionally siloed teams, and an opportunity to augment efficiencies in financial and regulatory processes. I'm really excited to share these updates with the community because I think we have come a long way and we have a long way to go. But this energizes us and we look forward to greater things on the A-Link front within ICN. With this, I thank you and wish you a great rest of the symposium. Bye.
Hello, my name is Jim Squires, and I'm one of the pediatric liver doctors at the Children's Hospital of Pittsburgh. I've been asked today to speak about evidence-based guidelines in practice. I have no disclosures. So our objectives for today's talk, we are going to review the historical basis for evidence-based guidelines, look at evidence-based medicine practice today, focusing on the role of evidence, as well as highlighting some of the shortcomings, and then look at A-Link and the future of evidence-based medicine in pediatric autoimmune liver disease. So what is the historical practice? In 2600 BC, the first reports of the practice of medicine were recorded by the Egyptian Imhotep, who described the diagnosis and treatment of over 200 diseases. And in 2019, the American Association for the Study of Liver Diseases released practice guidelines for the diagnosis and management of autoimmune hepatitis in adults and children. So how did we get from there to here? And what have we learned about evidence-based guidelines in clinical practice? Well, we can pretty much throw out the first 4,400 years, up until the late 18th, early 19th century, when medical practice was mainly driven by the, quote, experience of healers, with little to no scientific basis. However, over the last few hundred years, demands that the practice of medicine be founded on trustworthy, empirical evidence and scientific advancement have grown. And this might be best exemplified by this 1891 painting by Luc Fildet entitled The Doctor. Importantly, while some have viewed the work as a representation of the idyllic doctor tending to the patient, historians have debated whether there is a deeper commentary highlighting the shortcomings of the medical profession at the time. They note that for all the focus on the attentive physician at the bedside, the truth is he's really nothing more but a bystander, as helpless as the father figure watching from the shadows. It is thought that Fildet was pointing out that without appropriate incorporation of the scientific advancements that were occurring at the time, the practice of medicine, as had been historically performed, was rather inconsequential. So what has changed over the last 100 years? Well, focusing on the most recent period, we can point to the year 1911 and the publication of the transformative report by Abraham Flexner, which for the first time embraced scientific knowledge and its advancement as the defining ethos of a modern physician. Yet still, it was not until 1962 that the Food and Drug Administration passed the Kepner-Harris Act, legally requiring rigorous empirical testing of clinical trials in human beings to assess efficacy. It wasn't until 1990 that the Institute of Medicine officially recognized unwanted variation in medical practice, calling for the development and application of clinical practice guidelines. And then in 1991, that the term evidence-based medicine was introduced for the first time, stressing the importance of educating frontline clinicians in assessing the credibility of research evidence, really understanding that it was this unique skill that would be critical for a physician to determine how best to apply research results to their everyday practice. Therefore, ultimately changes that have occurred over the last 3 decades where there has been an emergence and integration of evidence-based medicine in its modern form, with its accompanying evidence-based guidelines. So what are the facts? Well, evidence-based medicine is a combination of medical evidence, theory, and practice. It does not offer new scientific knowledge, but rather it provides a framework for optimizing the practice of medicine. And the foundation of this framework is evidence. But when we talk about evidence, it is important to note that not all evidence is created equal. And guidelines are needed to be based on the best available evidence. Here we see that clinical practice guidelines are at the pinnacle of the evidence pyramid, built on the experience from various methods of evidence establishment. But all of us may not have the time or expertise to categorize everything we read in this manner. Therefore, some have presented the pyramid in various other ways, such as the blue pyramid on the right. Here, we can visualize that while no clinician could possibly practice without regularly relying on their own opinion or existing knowledge, this approach represents the bottom of the pyramid, and more often we look to expert opinions. It is these expert opinions which support the launch of more complex studies meant to begin to more definitively answer outstanding questions through clinical trials, which can then be interpreted and incorporated into practice through evidence-based guidelines. It is critically important, however, that evidence-based medicine develop a process for the assessment of the quality of evidence, recognizing that the higher the quality of evidence, the closer to the truth we can get. But even this was not always obvious, and by 2002, there were over 106 systems to rate the quality of medical research. This complexity was in part the motivation to improve the standardization of how to evaluate strength of evidence, which ultimately led to the deployment of the GRADE system in 2004. GRADE stands for Grades of Recommendation Assessment, Development, and Evaluation. GRADE provided a much more sophisticated hierarchy of evidence, which addressed all elements related to the credibility of bodies of evidence, including study design, study strengths and limitations, precision variability, applicability, publication bias, magnitude of effect, and dose response gradients. The success of the GRADE system has been reflected in its being adopted by over 100 organizations, including the National Institutes of Health and the World Health Organization. Still, despite all of its improvements and benefits, the GRADE system remains imperfect. For the women in the audience, this may be most evident by the constantly evolving recommendations regarding breast cancer screening. with various recommendations and guidelines available, depending on whether you're talking about recommendations from the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, or the American Cancer Society. For the men, we are also not immune to this, as prostate cancer screening recommendations differ between the American Urological Association, the American Cancer Association, and the U.S. Preventative Services Task Force. For all of us, a third example being the recommendation that all adults of a certain age take a daily aspirin to prevent heart attacks. While earlier recommendations suggested a daily dose, after new evidence became available, societies such as the American Heart Association and the American College of Cardiology updated their guidelines in 2019 to no longer recommend this preventative strategy for all. Complicating the issue even more is the fact that at the end of the day, the grade system is still somewhat dependent on the certainty of evidence. So how do you design and communicate evidence-based practice in rare diseases such as autoimmune hepatitis, where grade evidence, at least high-grade evidence, may be lacking? The answer is you be transparent about what evidence is available. This more filled out table showing that varying grades of recommendation can be paired with equally varying grades of evidence to guide clinical practice. In other words, you can still provide strong recommendations even if the evidence is low, falling back on the foundational bedrock of evidence, the expert's clinical experience. And so thus far, we have discussed how both clinical expertise and research evidence shape the development of evidence-based medicine. But there is a third principle of evidence-based medicine in keeping with a cultural change in medicine over the past 20 years. That being the growing emphasis on patient autonomy and the associated priority given to shared decision-making. And although widely acknowledged as desirable, the challenges to the implementation of shared decision-making remain formidable. Healthcare providers often face severe time constraints and might not have the relevant evidence readily available or the skills necessary to optimally engage patients. Additionally, tools to evaluate dimensions of quality, including patient and family experience, their values and preferences, and equity, are lacking. Furthermore, the infrastructure needed to support co-creation and co-conduct of these efforts may be inadequate. And this key challenge is underscored by returning to the 2019 practice guidelines. When looking at the authors, there is no patient voice represented in the presented work. When assessing what is new, there is nothing about increasing patient engagement, incorporating patient-reported outcomes, or prioritizing interventions that may be most impactful or meaningful to patients. And so how do we advance from here? Well, my hope is that it is A-Link to the rescue. I know Amy Taylor will be updating the audience on A-Link, but I'm excited to think about how A-Link can capitalize on its novel collaborative partnerships and deep clinical experience to drive the next phases of evidence attainment, all while fully incorporating the patient and family voice to reach the top of the mountain, if it were. So in conclusion, evidence-based medicine is a relatively new focus in modern medicine. It is meant to integrate the experience of the clinician, the values of the patient, and the best available evidence to guide medical practice. Recognizing the challenges of patient engagement and incorporation of their values, I believe that A-Link is well positioned to advance the field. I want to thank everyone, especially the organizers, Alex, Amy, and the rest of the team here at Cincinnati, especially our parent and patient partners who were involved, and I'd be happy to take any questions at the end of the session. Thank you.
Hi, today I'd like to talk a little bit about A-Link and how we can improve outcomes through research. I have no disclosures to share. First, I'd like to talk about gaps in care in autoimmune liver disease. There are current guidelines for the care of adults and children with primary sclerosing cholangitis, but these came out in about 2010. There are more recent guidelines for the care of children with autoimmune hepatitis, as well as adult and children with autoimmune hepatitis. However, when we look at these guidelines, we look at the care for kids with autoimmune liver disease, we've identified that there are some gaps in care and needs. And one of these is that optimal strategies to achieve disease remission in pediatric autoimmune liver disease are incompletely defined. These are rare diseases, so a lot of literature and a lot of practice is dependent on single center experience and retrospective review. There's variation in care practices and definitions, related to diagnosis, treatment, and monitoring. And so depending on center, or even depending on the provider that you see, you may have different management strategies and potentially outcomes. There isn't a current mechanism to implement research discovery into clinical care in a seamless type of a fashion. There's limited focus on mental health, quality of life, and patient-reported outcomes in autoimmune liver disease. And there's not a community for patients, parents, caregivers, and providers to meet and learn from one another and grow and improve outcomes. So this is where A-Link comes in, where we apply a learning health network model to help fill these needs and gaps in care. We recognize that multi-center collaboration is imperative to achieving better outcomes for kids with autoimmune liver disease. We utilize a learning health network framework, and there's a commitment to delivering the best care to kids with autoimmune liver disease, to expand the knowledge beyond single center and retrospective studies, and to develop novel, scalable solutions to improve outcomes and impact patient-reported outcomes, quality of life, which haven't been adequately addressed previously. So you've heard a little bit about A-Link and about learning health networks, and these are the sites that are currently participating from all over the country, representing different backgrounds, and we have all come together to help meet these needs and gaps in care and provide the best care for kids. Here's another look at the sites. And then we have our A-Link physician leaders and our ICN physician leaders. And you've heard from many of the A-Link physician leaders here today. A novel thing has been integrating the A-Link community of hepatologists with ICN. And you've heard a little bit about ICN, which is a learning health network model for inflammatory bowel disease. And this takes advantage of overlapping patient populations, since many kids with primary sclerosing cholangitis also have inflammatory bowel disease. This builds upon common therapeutic paradigms, such as immunosuppression and goal of remission in autoimmune hepatitis, which has many analogies to the care of kids with inflammatory bowel disease, as well as overlapping clinical practice and providers, especially since we're all within gastroenterology at many of our centers. So how do we use A-Link to implement translational research? So children, teenagers, and young adults with autoimmune liver disease will have better outcomes by utilizing a learning health network model to optimize treatment, limit medication side effects, reduce hepatobiliary clinical complications, and improve quality of life. And these are what we hope to achieve both through quality improvement, but also through translational research. So what is translational research? The translational science spectrum is indicated by this figure from the NIH. And this is complementary methods to advance knowledge and improve outcomes. It includes basic research, preclinical research, clinical implementation, and public health, with patient involvement being key and crucial to all aspects of this process. It's nonlinear. Information and discovery can go from one aspect to the other. And A-Link will first really focus on a lot of the clinical research and implementation as our first goals and outcomes. So this is a busy slide, but this is the key driver diagram. And then quality improvement methodology, this really anchors a lot of the work. And so we have our aims, our SMART aims within the patient population of autoimmune liver disease. And these are areas that we really want to work on and focus on. And I've highlighted some of the ones we've identified, including consistent, reliable care. And this is an aspect that research can really help with, not only implementing at our centers, but hopefully informing care at hepatology centers across the United States and across the world. So how do we do this? So we talk about compiling patient experiences through research, through an informed consent process for both patients and parents, with opportunities to learn more and ask questions about the study. Data collection for these projects will be tied to clinic visits, and data collected will include results of lab tests that are obtained just in regular clinical practice, report from imaging studies your doctor might have ordered, medications for autoimmune liver disease, complications of the autoimmune hepatitis and PSC, and medications too, growth, nutrition, and bone health, and symptoms and quality of life. And so together we're hoping through this project and through research to be able to evaluate the effect of corticosteroid type and dosing pattern on remission rates and adverse medication effects in autoimmune hepatitis. How do we use the best steroid, use it sparingly, and help kids and young adults get off of steroids with other medications to hopefully limit the long-term side effects. Other research aims that we've discussed and that are really can be possible through this partnership and this collaboration is to determine the factors influencing quality of life in pediatric autoimmune hepatitis and PSC. This hasn't been fully explored, and it's something that we hope to do through this project. We'd also like to prospectively assess the impact of GGT normalization on hepatobiliary outcomes in PSC. There's some indication in the literature that this may have an effect on outcomes, and we'll be able to test this going forward in kids. And most importantly, more to come. And this is where everyone joining together at meetings such as this, but also through A-Link connections and through the network, to be able to inform ideas on outcomes and research that we hope to achieve. So what about the nuts and bolts? So we've talked about a lot of things that we'd like to do, and I'd like to give you a little bit of insight on where the project, the research aspect of this, of the A-Link network is. So currently, the research process requires approval from an institutional review board. The Cincinnati Single Institutional Review Board has approved the prospective study to collect the data that I mentioned. However, we are working on contracts and agreements amongst the individual centers and Improve Care Now, as well as making sure that the sites approve the IRB application. There's a registry database to hold data that's built and tested in a secure fashion. Patient involvement and enrollment. There's also data collection, the need for review and analysis, and then sharing of findings with the community, which we think is really important. Is to be able to have this inform kind of knowledge of disease and best practices for how to care for kids with autoimmune hepatitis and PSC. And now I'd be happy to answer any questions. Thank you so much.